Okay. Well, welcome everyone. Thank you so much for joining this group of 3 roundtables. We're happy to have everyone here and see lots of familiar faces. So thank you all for joining. I'm Shireen Madani. I'm the UMEC member hosting this roundtable group. And we've got our UMEC support, Kate Mwenny here. She's our guru in the background. And we have our 3 roundtable presenters. So I'm going to have them introduce themselves in just a moment, but the format that we'll be using here is that all 3 groups will be able to present their roundtable, and we'll have a total of about 20 minutes per roundtable. So, the first few minutes will be presentation, and the second half of that will be discussion. So thank you all for being here. I'd like to offer our presenters the chance to introduce themselves today. We're going to use first names today, okay? Just to kind of keep things friendly and APGO worthy. So Erica and Brad, do you guys want to introduce yourselves?
Sure. So my name is Brad Brugman. I am the clerkship director at the University of Florida in Gainesville. And Shireen's, I guess, successor in that role.
I'm Erica. I'm a PGY2 in the OB-GYN residency program here, and I'm very interested in medical education, so I'm happy to be here.
Erica Wirt.
Sorry, you said first names. Erica Wirt.
Oh. I did say first names. I meant I'm not going to call you Dr. Wirt and Dr. Brugman.
Understood.
And I'm going to call Bob. Bob, would you like to introduce yourself, please?
Sure. Hi, I'm Bob Dean. I am core faculty at a residency at Mount Sinai, South Nassau. I also am the chair for Ross University Medical School, one of the Caribbean schools. And this is a program that was started in that school, initiated by medical students for the anti-racism reading program. It's done wonders for my education.
Wonderful. And Jody, would you introduce yourself?
Sure. My name is Jody Abbott, and I am a previous life residency program director, clerkship director, vice chair, assistant dean for curriculum. And in my current role, I'm still at Boston University School of Medicine, and I also direct online education for the AMA. And I'm going to be talking about gender equity because I don't know what people know.
Perfect. Thank you. So we're going to get started with Erica and Brad first. And they're going to be talking about using a grading committee to address grading challenges, which I'm sure is something that many of us have had to deal with. So Brad, sharing your screen, and I will mute myself now.
All right. So we've already introduced ourselves, but like I said, my name is Brad. This is Erica. We come from the University of Florida, and we wanted to share with you all an initiative that we started in the last year, which was using a grading committee to address challenges that can come up with clerkship grading.
So just to give you our context, I'm sure most of you know that there's this shifting emphasis now, starting actually this month, where the USMLE Step 1 scores are becoming de-emphasized, or going sort of towards that pass-fail system. And for this reason, clerkship grades are becoming increasingly emphasized and important for class rank and for getting into your desired residency program. So for this reason, in terms of what we were trying to come up with, we were trying to address the fact that these grades are very complex and maybe in the past haven't gotten sort of all of the data that they need from all sources, especially because sometimes, there's always bias, which is what we're talking about here, that different supervising faculty and residents can bring in when assigning their grades. There's also been a raising concern about reliability of the grades. So oftentimes that students will particularly notice is non-correlation of the assessments from instructors and from evaluators compared with their standardized exams. Additionally, there's already evidence that there's poor reliability in these assessments across clerkships. And obviously that can come with the nature of personalized opinions and things being subjective. There is emerging evidence that there's also bias in grading, as most of you know, and that we'll be talking about later today with some of our other roundtables. So oftentimes we see that there's lower grades in males, non-white students, and introverted students. They are often not necessarily immediately seen to be graded as highly. Students of color in particular are more likely to receive lower grades, and that's even the case when you adjust it for their MBME or standardized exam scores.
And I have citations here at the bottom of our slide, really that each of those points that Erica made are actually at this point well grounded in the literature. And for us, interestingly, some of the context that sort of bore this new idea arose within our own institution. So a group at UF really carefully examined the grades that students were getting on the clerkships and found that Black students in particular were receiving lower lower scores on the clerkships, even when you would match them for NBME. And so as an institution, we really tasked ourselves with finding ways to mitigate bias and increase the objectivity of our assessments. And so one such approach that we took on was adopting group decision-making. So I think there are a number of reasons that this can be beneficial. Assessors in the clerkships, whether it's the residents or the faculty who are assessing students, will notice different aspects of a student's performance to different degrees and use those to make their own global assessments. They also bring their own biases. For example, I myself know that I am a huge sort of stickler for professionalism competencies. And so for me, that's a huge component of my assessments of students' performances. Groups also offer perspectives from different levels of training, different clinical sites. And then I think particularly important here is different demographic backgrounds. And I do think it's worth pointing out that this is the model that GME uses, right? So all of us, of course, went through residency, and many of us sit on the clinical competency committees for residents. And some of that comes from an understanding that groups make better decisions than individuals. One of the, I think there are a couple other benefits that I think are not necessarily obvious or intrinsic to the benefit of group grade assignment. One is that these are really high stakes assessments, especially now more than ever, and you sort of relieve any single individual from the accountability of that grade. And I think that we are all probably quite aware that students more now than ever value transparency. And also what is, I think, becoming increasingly common is that as our grades become more important, we're going to see more grade grievances. And I think it lends a lot of credibility and muster when we can say that these were determinations that were made by a grade committee on consensus rather than, say, a single individual sitting in their own little bubble.
So this is just sort of the logistics of a grading committee. So in general, the members are the clerkship director, different site directors. For us, we have 2 sites, one here in Gainesville and one in Jacksonville, residents from both sites as well, and the vice chair of education, the coordinator, which sometimes I think may be forgotten, but they're acutely aware of some of that professionalism and some of the sort of checklists and things that lots of students have to be prepared for, as well as faculty from other departments. The importance too is that there's a diversity. So that's in gender, race, or ethnicity, years on faculty, years in residency, and the clinical site as well, because that'll give all those different perspectives that maybe you can understand the student that we are discussing better than others. And all members should have experience educating students and assessing their performance, be folks that are very motivated to kind of advocate on the student's behalf. It's a shared mental model, so it goes through sort of what the course expectations are, and everyone is very familiar with those. I'm particularly familiar as somebody who was here in medical school and went through these as well. And there's very clear delineation of what constitutes an honors grade versus pass grade, and what constitutes failure as well of a competency. In general, our meeting schedule, we meet about 4 weeks after the completion of a rotation where all the data has already been gathered. And typically the meeting will last between 30 and 90 minutes. As then the process is sort of we are adjusting as we go, but we especially review the students that were kind of at a tipping point of decision making. And there's a component of some of the data is blind. We don't always, get the data of all the numbers. Sometimes that's not really our purpose, but we're still adjusting that as we go.
Some of what we wanted to present were, I guess you could say, best practices. And some of these are things that have arisen based on our experience, but also in review of the literature from grade committees and other specialties. So I think that there are a number of things that we can do. One is have your members pre-review the data. So instead of just me as a clerkship director making my own determination, if the members of the committee have access to students' scores and competency evaluations, they can make their own independent assessment before they get input from the group. And that way, each of the members can explain his or her rationale for why they may have decided I assign this student an A versus an A-, etc. I think it's important to share perspectives. One of the things for us that's important is really being open to alternative interpretations. For example, we really value having residents on our team because they're the ones who are the closest peers to our students and often are the ones who have the most immediate memory of what it's like to be a med student, why they might do what they do. But then, someone, for example, on our committee, we have our vice chair of education who, has a more global perspective of resident education. And you just end up with different perspectives that come into your decision. I think one of the values of having your site directors is that they can really give contextual information to the entire group. For example, Erica had mentioned that we have our other site is in Jacksonville, and that site director interacts with residents and a patient population that would be completely foreign to us at our home in Gainesville. I think it's really important to acknowledge and address any personal bias that you bring. For example, I might work with a couple of the students on the clerkship and be really impressed or very attuned to their performance and might push for their grade. And I think being honest about your own bias is important. I think having addressing our own bias as it relates to demographics is also important, and whether it's ethnicity or gender, I think is really important to weigh. For this reason, there certainly have been grade committees that actually anonymize some of the data while they're reviewing, and there are pros and cons to both sort of sides of that. And then I think engagement and continuous improvement is really important. So one of the things that I have noticed in this process is that by meeting with the committee, we're able to sort of reassess our procedures, our curriculum, and then I think one of the things that's particularly important in my experience has been fostering consistency across the sites to make sure that students have equal expectations and assessment methods from one site to the other.
So we have two examples just from different students from different rotations where we used our committee to sort of help us along. Our first example, so we had one student, we'll call him Joe. He was struggling with medical knowledge, engagement, and team dynamics in the first 3 weeks of the rotation. He got targeted feedback at the first site with the site director. Then in the second half, he integrated that feedback and at site 2, received feedback from the residents that reflected that they had improved their professionalism, improved their other competencies as well. His oral exam score was slightly below average, but the NBME score was average. His final composite score bordered between low pass and pass. And the reason we bring this up is that the context of that whole story of that first half when struggling, when perhaps the whole first half of the evaluators may have seen him not really passing competencies, then needs to be seen in the context of the second half and how he took feedback well, tried to improve, and really be able to see that full context and on his behalf.
Yeah, and I would add that, one of the themes that has emerged is that one of the we know that, for example, students who come from backgrounds where, for example, a family member was a physician, they're going to adapt a little bit easier. But do you really score someone a lot higher because they're quicker to adapt if student A and student B both come to the same competency at the end? And so we were able to look at this student's, reaching competency by the end and really make a determination of whether he, should end up in the sort of low pass versus pass group. And so I think this was an example where our committee really helped us. I'll give you one other. This is very fresh for me and Erica. This is a case that we had quite recently. And I think for me as a clerkship director is, I think, one of the aspects of having a grade committee that I find most useful. And that's when you're discussing a possible course failure. All of us, I think, in this role would agree that this is one of the most difficult sets of decisions we have to make. So this is student Jane, who really struggled significantly in the first half of the rotation, in the same way as Joe. Medical knowledge, engagement, team dynamics, and she received very targeted feedback from me. It took about 45 minutes to set her up for success in the second half of the rotation. In the second half, unfortunately, she had similar difficulty, and we got really robust reviews from the other site director, from her residents, in agreement with this. Her oral exam and NBME scores both were less than 2 standard deviations below the historical mean at our school. And her final composite bordered between fail and a low pass. Our committee spent the bulk of our last committee meeting discussing the final grade for this student. And ultimately, I would tell you the determination was made that this student needed to remediate. And we as a committee then had to make a proposal to the academic status committee. And I think by having a group decision, it lent sort of robustness and reliability to that determination. So those are, again, just 2 examples we give from recent memory in our group decision making. That's it for us. We would love to discuss any comments or questions, but I also know that at some point we're going to be transitioning over to Bob.
Yeah, we have 3 minutes where we can take some questions. I put a question in the chat about whether any of your institutions are using implicit bias training. And thank you, Sarah Petruska from Louisville, also a Gator. So how are y'all using it, Sarah? And you have a question.
Actually, I do have a question. So we did some implicit bias training. I put it in the chat. So as a department, and then also with the admissions committee, and I think that's been great. On a slightly different topic, though, a question for Erica and Brad. I was wondering if you know any data or if you had any experiences of sort of like a groupthink function happening in the group environment where that momentum might be a different source of bias. If you had any reflections about that.
I think that is certainly a risk that you run in this sort of, with this sort of approach. One of the ways that other committees have tried to minimize groupthink is to make sure that all the evaluators or committee members can make an independent assessment ahead of time. I would tell you that our experience, and also based on what I've read in the literature, is that there does tend to be fairly high consensus. Again, whether that's groupthink or not, I'm not sure. But I would say I think I prefer the risk of groupthink to making than to my alternative, which would be to make a decision in a vacuum as just me, because of some of the benefits that we have gained by doing some group decision making.
Yeah, I can definitely.
Erica. Go ahead, Erica.
Sorry, I can definitely think of a couple of instances where we were not in agreement, and it came from not of overall, but just we brought very different views just based on different experiences, different days that we worked with the student. And so I think that that's definitely a risk, but I can think of times where we haven't allowed it really take over as much. Granted, that's anecdotal, and I recognize that.
Thank you, Sarah, for your question, Erica and Brad. And Jody, thank you for posting. Abbott has posted a AAMC guideline on DEI that includes implicit bias training for all levels. So there's a link there for you all to look at. And Erica and Brad, I'd like to give you just 1 minute to answer John Dalrymple's question. How do you deal with lack of adequate or reliable assessment data and metrics? I think that's the question that can't be answered, John, right?
Yeah, I guess it's more one of the challenges that we have, and we're developing a very similar system school-wide. And it's that I think what you mentioned, Erica and Brad, about how this is feeding back into evaluating your course structure, how you collect data. And this is certainly, we have knowledge assessments and some clinical assessments which aren't always reliable or documented, but when it comes to professionalism and behavior, it's often word of mouth, and it's everybody's opinion of what that looks like. And that's where we get kind of stuck, which is at the root of my question. But thanks for your thoughts.
Yeah, we do have that challenge as well. From a numeric standpoint, I would tell you that the most robust numeric data I get of competencies are actually in professionalism, because almost every person who interacts with the student is able to lend some assessment of their motivation, their timeliness, etc. So the numeric data I get is actually the most robust. And I'm like a little bit of a Excel nerd and like actually calculate out standard deviations. And so, as you said, sometimes it's word of mouth, but I'll try and lend some numeric data to back that up. For example, in the student Jane we talked about, one of the things I brought to our academic status committee was, these were the concerns about professionalism, but just so you know, her professionalism competencies were 3 standard deviations below our historic mean, which would put her in the bottom 1st centile. So I was able to say my data was robust, and even though there is some commentary mixed in, I can at least give you, that statistical information. I do that with my clinical competencies as well, by the way.
Thank you so much, Erica and Brad, and thanks to everyone who asked a question. Thank you, John, very much. And we're gonna switch gears now and move on to our second topic. And so, Bob, we'll have you present. And you've already introduced yourself, so let's go ahead and let you get started talking about the anti-racism reading program that you helped to develop with one of your students.
Well, yeah, I don't want to take credit for help to develop. I think I'm just part of it. And my medical student was supposed to present, but she unfortunately came down with that dreaded COVID and can't talk well this morning. So I'm on my own here. So that's Christy Leaker, 3rd-year medical student. So I'm trying to get this to advance. And so I'm Robert Dean. I'm also part of the Anti-Racism Council at Ross University. So the agenda is we're going to talk about the mission, the outline of the workshop, what the use of feedback and what our next steps were, and then handle questions. So one of the first things I want to do is start with a video from part of the TED Talk by Roberts, who's an American scholar, lawyer, social justice advocate. And
15 years ago, I volunteered to participate in a research study that involved a genetic test. When I arrived at the clinic to be tested, I was handed a questionnaire. One of the very first questions asked me to check a box for my race: white, Black, Asian, or Native American. I wasn't quite sure how to answer the question. Was it aimed at measuring the diversity of research participants' social backgrounds? In that case, I would answer with my social identity and check the box for Black. But what if the researchers were interested in investigating some association between ancestry and the risk for certain genetic traits? In that case, wouldn't they want to know something about my ancestry, which is just as much European as African? And how could they make scientific findings about my genes if I put down my social identity as a Black woman? After all, I consider myself a Black woman with a white father rather than a white woman with a Black mother, entirely for social reasons. Which racial identity I check has nothing to do with my genes. Well, despite the obvious importance of this question to the study's scientific validity, I was told, don't worry about it, just put down however you identify yourself. So I checked Black, but I had no confidence in the results of a study that treated a critical variable so unscientifically. That personal experience with the use of race in genetic testing got me thinking, where else in medicine is race used to make false biological predictions? Well, I found out that race runs deeply throughout all of medical practice. It shapes physicians' diagnoses, measurements, treatments, prescriptions, even the very definition of diseases. And the more I found out, the more disturbed I became. Sociologists like me have long explained that race is a social construction. When we identify people as Black, white, Asian, Native American, Latina, we're referring to social groupings with made-up demarcations that have changed over time and vary around the world. As a legal scholar, I've also studied how lawmakers, not biologists, have invented the legal definitions of races. And it's not just the view of social scientists. You remember when the map of the human genome was unveiled at a White House ceremony in June 2000? President Bill Clinton famously declared, I believe one of the great truths to emerge from this triumphant expedition inside the human genome is that in genetic terms, human beings, regardless of race, are more than 99.9% the same.
So this program and really that is a very, it's only about 15 minutes long. It's a very moving TED Talk to listen to. So this came from Elizabeth Stein's program. We adapted she's from the University of Washington. And what happened is during that summer of 2020, that terrible summer, that two of our students came, Della Rios and Kristen Ezekiel, came to us with the idea that there is a problem. We don't have enough information for students to start their career with. So three of the leaders in our basic sciences, Dr. Carrie Gasker, Parker, and Dr. Bobby Gearing, started this. And we started it as a program for first-year medical students. The very first time we did it was voluntary. The second time it became required at that point. So we wanted to have it to address the formal education about implicit biases and racism in the medical curriculum. So as we went with this, we had some goals. We set up that first we wanted to gain an understanding that race is really a social construct and not a biological or genetic risk factor for disease. Then we wanted to gain an introductory understanding to the role of racism, how it contributes to health equities. And then we wanted to discuss the process of becoming an anti-racist. So this should be familiar to a lot of people, but this is the movement from becoming an anti-racist. When you sit there and you say that there are things that you want to achieve in this, when you sit there and say, you move in the fear zone, you don't think racism is a problem, you're worried about it and not comfortable with it, to a learning zone where you can go ahead and recognize that, that you have privilege based on this, to a growth zone where, you can promote and advocate for anti-racism issues. So with that in mind, prior to the workshop, everybody was given access to the book by Dorothy Roberts. That's the woman who was in the video, called Fatal Invention. And there are 3 chapters that we give, and it's 1, 4, and 6 that are required, although it's encouraged to read the whole book. One is the invention of race, and it's a very fascinating chapter. Medical stereotyping is 4, and embodying race is 6. And it's a devastating book to read for any of us who are in medicine. So prior to the workshop, we had facilitators trained. Workshops are usually 2 co-facilitators, a faculty member, and a senior student, a student who's either been through this or had some other training, and 6 to 8 of the incoming first-year students. And this is done in the very first week. All the facilitators have to do pre-workshop training and participate in practice groups prior to they start. And then in that aspect, we then go through in the workshop itself. Everybody first gets a general large group meeting, and then they're broken out into workshop sessions with the smaller ones. And they everybody names themselves and give maybe some little talk about where they feel they're from. We review what's called community agreements in there, and these you really have to watch because people can feel there are issues as we go through those. So the community agreements themselves have these different things. I'm not going to go in detail, but the benefit of doubt, understand that you may be uncomfortable during this. And if you are somebody who talks up all the time, try and listen. If you're somebody who doesn't talk up, please give us your gift of thoughts. Self-focus, think about what's happening in here. Try and understand the difference between the intent of what you said and the impact it may be on someone else and how different they might be. We talk about mindful listening, confidentiality. You're not supposed to bring any of this out of there. Professionalism, it's a good introduction for our students, and the right to pass and not talk, and any additional agreements that may come up inside the premise itself. So we have discussion questions that are defined in there. And this is about a 90-minute session, and have your introduction, your beginning review of your community agreements and things. And then, you ask the first question, what is your reaction to the book? What were your takeaways? What did you get out of this first part on there? And after discussion, and the facilitators moderate the time on this, and then after a certain point, you'll bring up the second one. Is that essential premise of the book is that race is a political and social construct? And how have you seen race in this way influence the health of individuals and communities? And, we try and draw out those who won't talk and try and get this going. And it's usually a very, very robust discussion. The third one is we talk about what strategies that you might employ to uncover your own biases and prevent some unconscious judgment from affecting you and your interaction with peers, colleagues, and patients. In that aspect, we did do look for feedback, and we've had 4 sessions, and in fact, the 5th is going on right now, and I am not participating this one, and I have participated in all 4 so far, but this is not going to fit my schedule. I'm doing something else. So we basically talked about a previous exposure to the idea that race is a social construct, and they basically got pretty high levels that people were saying that the numbers were pretty good. So you see the people in there. And then had this program change your ideas of race, and it, again, moved up very, very well. I mean, we have a pretty large class, and then these groups did very well at that. And you can see that the numbers consistently went across here and rose. It being a mandatory, we had a lot more participants in all that. So then this was the group, a lot of facilitators in the beginning, and then the number of students who were available to take training to go ahead and become, and then for the second one, you could see that the number of faculty facilitators stayed pretty much the same, but the number of students grew tremendously, and we have continued to have that same type of growth. It is a popular and appreciated program that we have there. So I'm going to stop there and just see if there are any questions that anybody wishes to ask. And I'm going to stop sharing the screen at this point.
Bob, I posted in the chat that one of the things that I really liked about this program is that it seems like from the beginning, there's an emphasis on creating a safe space. And acknowledging that this can be uncomfortable, but it's so, so important. Yeah,
the community agreements were very, very important in there, and is really well done. And I let me make clear, I've been a participant in this. The people who really put it together, who declined to come to this, were Dr. Gearing and Dr. Gasker and Dr. Parker. You know, it was offered to them, and Dr. Gasker was going to, and then she had other commitments, and Dr. Parker has since left the institution to go to another one, and Dr. Gearing is still there, but they're very, very tremendous. I think I'm not looking at the chat, but I'm seeing some things pop up. The safe spaces are for everybody who's in there.
Thank you, Camille, for your question.
Yeah. So I think that we all need to have those in there. And, you know, it is a growth for everyone. And I will say that I grew by participating in this myself. I think it's a benefit to the facilitators. I wish ones who were more reluctant should come as faculty. And there's been a discussion about requiring the faculty to participate in this too. That has not come along because that has to pass through a different thing. Curriculum committee got this approved to be part of the curriculum. Getting faculty to be required is a different thing. I think it has to go through the Senate and some other things. And so we have not, you know, there's always bias training and things like that, but this course is not required for them.
Camille's question is a good one, though, of course. Who are the safe spaces for? Is it for diverse groups or for major groups? Camille, do you want to add anything to that?
Thank you, and thank you, Dr. Dean. Nice to hear from you. I did promise I wanted to attend your session, so thank you. I'm really excited to have heard from you.
Thank you, and I will attend yours too.
Downstate graduate from medical school, so psyched for my own institution. Yeah, no, my question was really, sometimes, unfortunately, as we think about where we or where we stand on the on our journey on that infographic, sometimes dominant groups are sometimes wanted to feel more comfortable, so to speak, than the people that have previously been oppressed. And so when we think about that book, for example, called White Fragility, and we've seen that in the media and social circumstances where others, you know, use, you know, weapons, certain weapons, crying, etc., because of their discomfort. And so people from oppressed groups are somehow meant to feel that because they're stating their trauma, they have to make others feel more comfortable. And so that's what I was asking regarding safe spaces. So again, you know, sometimes we have to be careful when we ask these questions because we have to make sure that others feel comfortable. So that was my question. So thank you.
Thank you, Camille. That's so, thank you for pointing that out. And Jody, thank you for sharing in the chat. I would share that we struggle with having our peers from diverse backgrounds feel psychological safety in our equity sessions. Yeah. Well, Bob, thank you so much for your thoughts today and your presentation. Please let your student know we missed him or her today and are sorry they were not able to join, but please let them know generated some good conversation and interest.
Thank you. Well, I'm going to try and see if I can get her to see the recorded version. That would be
perfect. Yes. So we're going to move on now to our third and final roundtable in this group, presented by Dr. Jody Abbott. She, him, zer, them, time for gender equity for us all. Thanks, Jody.
Thank you, Shireen, and thank you to the other presenters in this session. I want to give a shout out to Sarah Petruska, who is my co-presenter and who is my main ally in helping transform a roundtable into this session. So I don't have slides, but I love that all of these sessions are really about educators acknowledging our biases and, you know, working and struggling to bring our best selves to work and into our personal lives and the wholeness of who we are. And I think that this is something that these issues weren't acknowledged years ago. So even though we aren't good at it yet, we're working towards it. And so I think that we can all feel some hopefulness that we are acknowledging that these challenges exist. So for this talk, I hope everybody has their chat open because I want to start just by asking a couple of questions. I want to ask, how many of you are familiar with presenting at a session where you are asked to share your pronouns? And I saw a couple people have pronouns. I put my pronouns in. My pronouns are she, her. So if you just do a thumbs up or a something, if you have ever been in a meeting where you shared your pronouns. And so we have a few. And so the next question, oh yeah, oh good, more are coming. Okay. Excellent. And then my next question is whether any of you in your standard weekly, monthly, daily conferences, such as sign out, board sign out, if you ever do have you normalized sharing of pronouns in those kinds of sessions? Anybody there? Okay. So, so I will start by saying, you can't see my gray hairs perhaps, but I have welcomed them during the pandemic. And I'm very last century in all of my training. And I'll tell you that my first day of medical school, or the first week at least, we had our doctoring session. We were supposed to go around and say what we wanted to go into. And I had said that I was interested in surgery. And the preceptor of my session said, well, you can't be a surgeon. And I said, well, who says I can't be a surgeon? And the preceptor says, well, because no one will send you any patients, because surgeons are supposed to be physically imposing and skillful, and you won't get referrals because you're a small woman. And I said, well, he, so I like got my gear up and I looked around the room and I said, well, he, I point to my male colleague. I don't even know any of these people. He might not send me a patient, but she'll send me her patients and she'll send me her patients. And I'm very happy in my career in OBGYN, but I really think that so many of our current practices stem again from the same impressions that we had going back. And so fast forward to, I don't know, 6-8 years ago, when we have a transgender student in our school, and I'm one of those like, hooray, we're so proud, go you, progressive white ladies, known for our tone deafness historically, and many equity issues. And the student, after the first day of OBGYN, had said to me, could I talk to you later in the day, Dr. Abbott? And I was sure that somehow I'd be applauded about our progressiveness of our clerkship. We have several cases of, women who have sex with women in the curriculum. And, once or twice, we definitely mention non-binary people. And the student came to me and said, the entire orientation, you talked about your patients with a she pronoun. And I was speechless, which, if you know me, is not my usual state. And I was just so surprised. And then the next thing that came into my mind was women, like, this is women's health. If we don't have women, if women don't have women's health, like, what do we have? And I would say that I didn't say that out loud, luckily. I said, thank you so much for putting that out. I'm going to think about it. And I think that in the past few years, I hope that everyone has noticed, even APGO has that we've adopted in a lot of publications the use of birthing people instead of women. And yet it was really, really transformative for me to be called out. And I think that this is something that we learn. And what I've realized over the past few years is that if we can transcend the expectations that we have, not only will we free our learners and our students, and I think that's the urgency with which we need to do it, but we also free ourselves of these expectations, and we're gonna, help bring our place into a better world. And so now I'll just share some data real quick. And I think everybody knows this, and this is why I didn't put it on slides, but actually Dr. Cox had shared in the literature sharing a recent study showing, looking specifically at the gender identity, sexual identity, and racial identity of students in the senior survey from the AMC, looking at experiences of harassment. And not surprisingly, female students, LGBTQ students, and students of color are more likely compared to white male students to experience episodes of discrimination and harassment. We have female LGBTQ students of color, trainees experience patient biases more likely, and there have been multiple studies showing this and the contribution that it has to burnout, to career change, to leaving academic medicine, and to specialty changes for surgeons. We have female physicians. We know that there continues to be gender salary bias differential, and a recent study showed that over your career, the differential is at least $2 million between women physicians and male physicians. And we know that female representation in academic medicine, starting with promotion, full professor, associate professor, is lower than men, and as well as NIH grants, the number of chairs, although there are certainly more female chairs in OB/GYN and female chairs of color. Shout out to Dr. Claire, but editors as well, and certainly in positions of leadership. And because we also have a bias in promotion, where it's much more difficult for educators to get promoted, and we do have, even in OB/GYN, a higher percentage of women educators, I want to sort of open up this idea of if we welcome everybody, we're going to make more space for everyone. So what I wanted to talk about as well, so in our school, we are lucky in that our students show us the way, and we have a number of students who are non-binary and gender diverse. And we also have residents in other training programs. And so some of you I know had seen that I put a paper that I believe is in the chat, and also, or thank you, Sarah, for Sarah's adding the resources to the chat, a paper that had been published in New England Journal by one of our residents, talking about the challenges of being a transgender student of color, now physician of color. And so as we have sort of looked at our program and looked at our environment for how we can be more inclusive, a number of changes have been decided to make, but I would say it has been our students and the residents, and we did have residents from family medicine who are also rotate with our residents on the labor floor, and that really spurred forward. And so we do currently have twice a day on the labor floor when we do introductions with the nurses. Pronouns are now included. It doesn't always go smoothly. Not everyone shares their pronouns, but it is one step on the road to help increase inclusivity. And so I would, for those of you who are now going to meetings where people share, and so many of us, it's now sort of second nature for me when I look at my Zoom title to see, did they take out the she, her part? Or I'll just add that in to really be that welcoming. And so another experience that I had relatively recently was as a part of the Boston Obstetrical Society, which is the longest existing medical society in the country. It's 150 years old. And so as you can imagine, it's very old fashioned. Women weren't accepted into the society until 1974. And recently we updated our bylaws, and all of the bylaws had the gender he. And so initially we went through and put she, he in, she, he. And I said, well, why don't we just put they, because now we can welcome everyone. And as many of you would not be surprised to hear, there were a lot of people who were very personally aggrieved at the use of the pronoun they as an inclusive pronoun. And I think that, as I said, we really want to free all of us. And so we want to be able to be inclusive of everybody. And so the nice thing was that although many people didn't understand exactly why the they was there, that people were open to it. And we did, well, once we can meet in person, somehow our bylaws say we have to meet in person to change them, but we do have an intent to formalize those guidelines. We also have a lot of resources. I think that we've had other workshops at APGO or maybe CREOG about looking at gendered bias in student recommendations. We know that best practices for how to create inclusive environments have to include climate culture surveys. And that's essentially what we have with the graduate questionnaire. We all know, the graduate questionnaire is of people who aren't at our school anymore, or they may have joined as residents, but they aren't actually students anymore. And so if you want more real-time information, you need to seek that out. And we know from best practices in terms of prevention of harassment, we need to be able to ask people more often than just wait for people to place to put complaints in place. And we also are well aware of the opportunities for bystander trainings, as well as what we call microaggressions. And I think that, the microaggression is along the spectrum to what some people now call microassaults, or just would be called harassment. And so I think that we need to be careful. I think the term microaggressions itself is a form of white fragility, in terms of, we don't want people, if there's something that you do all the time, we don't want you to feel too badly about it. So we'll say it was micro, because we have lots of data now that microaggressions dramatically factor into, for instance, people's reluctance to return to the office in many different types of industry. So I am hoping that we can have, I want to have a conversation. We still have 11 minutes. I have more to talk about, but I'm hoping that we could have some sharing about efforts that you guys have made in your institutions to be more welcoming and inclusive, gender non-binary. For my presentation, I didn't add specific data about our non-binary patient population. I think for some of us that has indeed been a motivator to be more inclusive. And I think that that is certainly very valid. That if we as OBGYNs want to include gender non-binary patients as part of who we serve, we need to be able to provide opportunities for them. And I think many organizations, certainly I'm part of one at Boston Medical Center that has done many adaptations to the EHR. And so I didn't want to address that. I did want to focus more on our learning communities. And so I wonder if there's anybody who'd be able to share any initiatives that have taken place in your organizations to add more inclusivity for gender non-binary members of the team.
Well, it's so interesting that you bring this up, Jody. At our institution, we have we're going through our, we're in Florida, and we're going through our first time where we have a student who's transitioning. And so this has been, great to hear your perspective and your input, and even just sort of some of the logistic and legal things that have to happen, right? You have to work with the registrar up the hill, and you have to figure out how to get, all of these things changed. But the feedback that we got back from the student was just that they were really thankful for people who were willing to listen in a non-judgmental manner. And I think when you have one positive experience, it helps to perpetuate things. I suspect we'll have more students now who come to us and share this with us, because maybe they are feeling, we hope that they're feeling this is a safe space.
Yeah, I think certainly as the field of OBGYN, I think it's really important. We know all of the data that says that we are better physicians when we are diverse, that we provide better care, we learn from each other more effectively. And so we certainly would want to recruit gender non-binary students into our field. And so we have to be able to demonstrate openness as students come through our departments, as residents rotate through, because, like all other elements of society, part of it is taking that first step to identify that there's something we'd like to do better, and the next step to start to move towards that. One of the things I put in the chat, and I think it's really important, as we sort of have this hyper awareness, and I suspect your environment was like ours, you have this student and everyone wants to put a little bubble around them. So only wonderful things, they'll only have wonderful experiences. And so sometimes we forget day in and day out of the everyday I will use the term microaggression, so it's because it's so common, although I feel like it should be more escalated than that. But the everyday disrespect that is put onto our learners, our students, and our residents, that often comes from gender as well as from race, and certainly from people who present as non-traditional in their gender presentation, often do exhibit negative feedback from the staff as well as from patients. And so one of the things in the chat is about the opportunity to have policies in place, to make sure there are policies in place, because I think we know from other examples that when we have someone, if you are supportive of the person, they might not want to share with you this other terrible thing that happened because you're so nice and they don't want you to feel like you failed, right? So like you're the nurturing mentor, and they just don't want to disappoint you by having you recognize all the other horrible things in your organization. And so it's really important to be able to have policies in place and to share those and say, if you do experience these things, we want to know about it because we want to make our environment better for you. And thanks, John. John puts in about collaborating in co-production with students, which is such a great point. And the faculty development piece, and sorry, I'm not making complete sense, but I would love to have you unmute, John, and share some of the things in here. That would be great.
Yeah, we've launched into a significant effort at Harvard Medical School around sexual and gender and minority health education.
Mm-hmm.
We were fortunate that it was underwritten by a philanthropy, and we were able to bring in key faculty and some curricular fellows to help with this. But some of our key points we recognized early on was students were often leading the way, but we also didn't want to burden the students with having to teach faculty on topics related to sexual and gender minority health, as well as issues around anti-racism, of course, where there's a lot of overlap. But certainly the students are the ones experiencing the curriculum and experiencing the learning environment and getting their input on ways of addressing it, however they could. Again, not relying on them, but getting their input. They often wanted to, and so that was essential. We also realized that the faculty wanted to do the right thing, they just didn't know. The ignorance ran deep, and so we recognized that we had to bring our faculty up to the level that the students were at. And so that meant developing faculty development materials and modules just on the various topics about terminology, developing a terminology guide, something as basic as that. Went a long way. And then my last point was community engagement, bringing in a community advisory group that would provide panel presentations and feedback on some of our opportunities for curricular engagement. Happy to talk more with anyone offline.
That's great. Thank you so much. And I know that, for instance, I know that there are groups in Minnesota that have done a lot of work on this, and in the chat are some of the policies from the Mayo Clinic about. And again, I just want to go back to the idea that, experiences flow from policy. And so if there's policies about whether or not your organization tolerates disrespect from patients towards providers, will go a long way to whether or not your trainees feel empowered to report it, to identify it, or to suffer in silence, And the Mayo Clinic has some policies that there's a link to there. And I know that the University of Minnesota Family Medicine Program has they have several, I don't know what they call them, sub-cohorts of their residency, and one of them are for gender non-binary trainees with a focus on gender non-binary health. And so I think, again, we can learn from our colleagues about how to help support, to identify. And I think part of it is just to acknowledge a world in which there's a lot more people that are different than me, than people who are like me. And I think we all make that assumption, but sometimes you have to verbalize that and demonstrate that in your policies and your materials. And so I think that, we're everybody's sort of constantly in a progress of re-envisioning all of the programmatic elements that you have. But one way to make sure that you are looking at that lens is the messaging that we're sending both to patients and to employees and trainees about how welcoming we are of people who are gender non-binary, and how supportive we are about making sure that we are uplifting everyone equally. And again, I think that's the unifying theme through these three presentations. And it's so great to have an audience of you here who are interested in working on these things. And, we're really all a community working together to create this improved, ever improving learning environment where we can see the value, the virtue, and hear the voices of the beautiful diversity that is our community. So thanks to everybody for being here today, and for my colleagues who got to go first, and for letting me go last, because I do love to wrap up. But I will send it back to you, Shireen.
Thank you so much, Jody. I put in the chat, you're such a pro. I always love working with you.
You're so sweet. And thanks to Sarah too.
And Sarah, thank you. You've been the like the wizard behind the curtain, posting all of the awesome resources, and just really appreciate the engagement from everyone. Thank you, Sarah.
You're welcome. The plan was for Jody to share her thoughts. That was our skill.
I like the plan, and it's always great to hear. John and Camille, thank you so much for speaking out. Especially, it's always great to hear people from different communities or different institutions, different parts of the country. We're all working on the same things, I think, and we're all at different stages of where we are there. But one of the great things about APGO is that there's so much to learn from one another. And I always leave these meetings feeling really inspired. So thank you so much. I learned so much from all of you. I'll just say really quickly, Kate, thank you for posting just logistic stuff. The overall FDS evaluation will be emailed to you, so you can fill that out for your CME. And the CME verification form is going to be at the top of the agenda in the platform. So thank you all so much for being here. And hopefully you'll be able to join us for the plenary talk that's starting in 4 minutes.
Bye,
Thanks,
everybody.
all.
Take
Bye-bye.
care.
Thank you, Shireen. Thank you.
Thank you.